Hello, everyone. Thank you so much for joining the webinar tonight. I should say hello, good afternoon, and for some of you, good evening, depending on your time zone. Thank you so much for registering for this webinar tonight. I know that most of you have work today and many of you just getting off. I am Brenda Sharp McCarson. I am a dental hygienist who has worked for Brasler. My full disclosure up front, I'm the National Manager of Hygiene and Hand Instruments for Brasler. My only other affiliations are that I have many very good friends who serve in roles very similar to me. I've been a dental hygienist for 43 years. I think once you go through hygiene, unless you give it up, you're always a dental hygienist. But I have not practiced in a while. I'm currently not practicing. So hopefully tonight there will be some pearls. We're going to move very quickly on the front end and get to the instruments that I think will help. I know we all have our selection that we've been using since dental hygiene school. Some of us have changed, but hopefully we'll move through some new instruments that will help you, especially in today's current environment. So let's get going. Our objectives, which I'm sure you have read in advance: review design, function, and use of popular instruments that are commonly used by the dental hygienist. I do know and acknowledge there are many dentists that are viewing this course, and you probably use many of the same instruments. Identify new instruments that will maximize your dental hygiene treatment procedures. And I want to introduce some advanced instrumentation designs that have been around for many years, at least as long as I've been a dental hygienist. And hopefully those will help you, especially where you are not using the ultrasonic. I know we'll talk about that as we move forward. Little review from the 1960s. These are kind of fun pictures I do like to show. If you'll look at, and this 1916, that I do believe that is a dental hygiene school. But notice there are no overhead lights. I don't see them if they're hiding, and I really never, every time I look at this, I see something different. But I don't see any overhead lights. And we move to the 30s, that's pretty typical. No gloves, no mask. Our nice little hat has evolved. In the 40s, again, no PPE. If you look to the back side of the dental hygienist, you see the little cold sterilization tub. Now, I know some of the younger dental hygienists, you have no idea what that's about, but even I, in the 70s, we did a lot of, we thought we were sterilizing, but we were just disinfecting with cold sterilization. We don't do that anymore. And then as we move to the 1950s, still no PPE. Things start changing in the 70s and 80s. I have seen with my travels the blue chair. I do think they still exist. Seems like all the offices except for one that I worked in, I had some similarity to that design. I did cover up the cuspidor. I just couldn't handle the spit. This is the big, what do we call that, bouffant? I don't remember that hair in the 70s, but that's supposedly a 1970s photograph. We had the heavier handpieces that were powerful, 500,000 RPMs was the speed, and we were removing some heavy stain. We were also removing enamel and exposing the patient to a lot of pain and sensitivity. In the 1980s, that's when we really began to embrace PPE. I believe it was 1981 that we were presented with this disease that we really didn't know what it was, and it became labeled, and I think we did label it in 1981 as the AIDS virus. And OSHA stepped in and required that dentists, dental hygienists, anyone working in the mouth, as well as medical professionals as well, that we wore eye protection, masks, as well as gloves. I mean, I remember in dental hygiene school working on the more difficult patients where they would bring in the local prisoners. And I think back, never wearing a mask, never wearing eye protection, and never wearing gloves. And it's pretty scary. But, when I'm doing this live, I kind of throw my hands up and say, I'm still here. Wasn't the right thing to do, but it was the reality of how things have changed. And they're continuing to change. In the 80s, 90s, and really I would say the early 2000s, we were still out. If we look at the focus on hand instruments versus ultrasonics as a dental hygienist, we were spending the majority of our time on hand instruments because those of us who that was what we were taught. You probably spent early on, I know in the 70s and 80s, we probably spent 75 to 90% of the time with hand instruments. And we did a darn good job. We weren't worried about ergonomics, and that's why so many of us now have retired with major issues, but that is what we did, and we did a good job, and we were comfortable with it. Ultrasonics, very minimal use of the ultrasonics in the early 70s, 80s. Most of the ultrasonics were, at that point, were, super gingival only. As we get into the 2000s, things did start to change. Of course, we look and we see, that's my friend Nancy, with the mask and the glove, but no eye protection. And that's my granddaughter. I never occurred to me, when I'm sitting back there thinking, okay, in the very near future, we're going to be back to having the old days. We had our hair back in the day, as my grandchildren would say. And many of us on this webinar, back in the day, our hair was pulled very tightly and, out of our face. So I'm sitting there not thinking anything about it other than how, she's, a very good dental hygienist, but things begin to change. We evolved to magnification, so many things, and as well eye protection for the patient, as well as the clinician, especially the clinician. At that point, we're changing. We're beginning to change, and I think we saw this in our this dental hygiene education begin to change and more focus on ultrasonics, where there was my years in the 70s and 80s, there was that one device in the clinic, and you would eye it, and it was like whoever got there first, that's who used that ultrasonic device. But how helpful was it? Because all of the tips were so bulky, they did not go, even with the worst perio patient, they really didn't fit subgingivally. So we evolved to some amazing, not only devices, but the ultrasonic inserts, and then of course piezo, which I'm a very big fan of. And if I went back to practice tomorrow, if I had to purchase my own piezo, that's what I would be using, because there's less heat, a lot less water, so reasons for that. But here we are, we kind of flip-flop. The paradigm changed through change in technology and the tips available, and probably in the toward the end of early 2000s, mid 2000s, we began to change, and we were using ultrasonics probably 50-75%, depending on when you went to school. And I can remember even last year standing up in front of a group, because, I've always done live and I do a lot of hands-on courses, in saying, hey, this is 2019. If you're not using ultrasonics the majority of the treatment procedure, then, you need to become current. And although I believe in a blended approach, it just makes sense. And it's standard of care. And that's why many of us are struggling right now with this new pandemic. Well, not so new. It came upon us in January, and we really found out about it in March. Things have changed. This virus evolved and rocked our world. But you know what I think about? I just visualize that famous poster, "You can do it," and we can do it. We're educated, we're smart men and women, and we're dental hygienists. We know how to protect ourselves and how to protect our patients. But we do have to rethink some things, because the CDC recommended that we limit or avoid aerosol generating procedures, and whenever possible. And that means that we need to avoid the use of dental handpieces and the air water syringe, avoid use of ultrasonic scalers. You see I have that in bold. Imagine that. And prioritize minimally invasive atraumatic restorative techniques using hand instruments only. I say, if I was in clinical practice, I'm not. So what do I know at this point in time? That I would be very comfortable with hand instruments. But when you get into that difficult, tenacious burnished calculus removal that someone else did, because we have never had burnished calculus on our patients. We just don't do it. It's always the other hygienist. But hand instruments, there are hand instruments that we can use to efficiently remove that burnished calculus. And we're going to talk about that. But our world has been rocked. This is our new PPE. Not when I look at this, many of us we were wearing the disposable gowns. We had our magnification, which, that's not really, to me, it's a part of our standard PPE, but, that's just protecting our eyes and we can see better. But we were wearing eye protection. But a significant change, this outer mask there was no inner mask of a N95, but the outer mask, that was it. And it was, in many cases, a level 1. And I've been preaching for years at ultrasonic hands-on courses. The minimum, really, if you're using ultrasonics, you should be at a 3. So, we didn't even have the 3 in our office. It was like 1. So a tremendous change in the way we dressed. And then we go back to this, telling me, the CDC, making this recommendation that we should avoid the aerosol generating equipment whenever possible. And that's exactly, this child, the fit, most of us felt that way. And life goes on, and we make adjustments because, again, we're going to deliver standard of care for our patients no matter what. So we look, these are the things that we're supposed to avoid. We use these every day. And I was a huge fan of the air polisher. In fact, to date myself, I had one of the first air polishers. I was in the early, well, I don't want to say trials because it was like 70, 78, but I had one of the first ProfiJets. It was the great big box. It was actually the blue one, not the yellow kind of tan taupey box. So I can't imagine a day without using the air polisher, but that's one of the biggest aerosol producers. Even the most current Cavitron units, the Sterimate, and they're probably, one that's even newer, but I mean, these, you can adjust. We still are dealing with the aerosol, your air water syringe, and then of all things to tell us that, and I think this is still, do you do it, do you not? Even using the low speed, the air driven. So lots of changes, and we're dealing with, not using these things or adjusting what we are doing. So now we're back. We have the paradigm has shifted, and we're back to the use of hand instruments the majority of the time, and ultrasonics as absolutely indicated. Now, I do know this is a very controversial subject. I realize that, I understand it, and I will disclose, I saw my dental hygienist last month, and she used the piezo on me. I had no problem. She was using a PureVac high-speed evacuation device, and I didn't see. I know the aerosols were there, but she managed it beautifully. So, I think that we've got to do our due diligence, but each office sets their protocol, and based on what type of PPE you have and how are you going to manage the aerosols. But, the reality is this has flip-flopped. These are some of the things I'm involved, as many of you are. We are on Facebook, and we are we're members of different groups. And I pulled, really, there's so many out there. It's like, the old days, and every disease, the snake oil guy came around toting his new invention, and it was going to cure everything. There's so many things out there. And I really, because I'm a terrible salesperson. I work for a company that we sell things, but I'm terrible. I love to teach, and it doesn't matter if it's a Brasler product. It doesn't matter. We don't have any. We have a few of these things, but I'm not going to point those out. But I do. These are the things that I've heard the most, and had positive seen positive comments. And if you look, I'll talk about first, and again, this isn't hand instruments, but these are some of the new normal things we're using. I think a lot of offices are considering the cordless hand pieces, the low speeds, for polishing. We created the monster, that patient, that no matter what you do, if you don't polish them, they didn't get the service that they just paid for. We created that, and even we went through the selective polishing days. It's hard to retrain our patients. So we are still polishing, many of us, but we're polishing, and we're following with the HVE so that we don't get the splatter. But the hand pieces, the cordless hand pieces, they don't run at the same high speed that your low speed hand pieces. Your air driven, your air compressed hand pieces are going, 2,500, 3,000 is much faster than on the low speeds, because these are battery powered. So I do think you have less splatter. So, that's one option. Of course, we're wearing the level 3 mask, we're wearing the N95 with the many of us with the level 3 over, or maybe a level 2, and you're discarding those very frequently. The pink pedal, that's just, it connects to just a regular low speed evacuation. So I know some of you are using it. I'm not sure how much aerosol, because the aerosol is the big thing. The water is one thing, but the aerosol. is another. The Mr. Thirsty, that I believe, if I remember correctly, that Mr. Thirsty can removes like 90% of the aerosols, the aerosol production, right at the site. So, that's good, but it's very bulky. I was looking at, and if you get a chance, go online. All of these have a video. I think that's real important to look at the videos. That would be a whole lot in my mouth. And I have a big mouth. Some of you know me. My mouth is really big. That's a lot. It's like a mouth. You've got the mouth prop. You've got the ivory leaf. That's a Colzer, I think, product. I think and then the mirrored problem. This is the PureVac, and this is the New Bird. Those seem to be really popular because what that does, it frees up one of the hygiene hands. You've got your mirror and your HVE in one hand. So I think that really makes a difference. But all of these things are out there and are being promoted. I think most of them are back ordered. One thing I do want to mention is the cord ease as far as cord management. I think those are excellent. They were invented by a dental hygienist. It doesn't, it's not your aerosol control, but it's managing the cords, and there are even adapters now available for those larger cords. A little, also controversial, and then, we're getting, this is all leading up to our actual procedure to get in with our hand instruments. And what are we going to use, or what are we going to do differently? The American Dental Association, and, I originally had quotes on this, but I changed it because, the American Dental Association advises that dental health care professionals consider using a pre-procedural rinse with a very diluted hydrogen peroxide or an iodine rinse before a procedure. When I had my procedure, I believe it was Peroxyl or one of there are other things on the market. I just, like the kind of a gold standard versus another gold standard that's very inexpensive, over-the-counter, regular hydrogen peroxide. The challenge here is making sure that you are diluting the hydrogen peroxide. And I know some of you are using hydrogen peroxide. The norm, I think, is 2 to 3%. And the recommendation is to dilute it to at least 1.5% or lower. I know some offices are adding a little mouthwash just to make it the flavor, because if you're rinsing for 1 minute, that's a really long time. But just another way to reduce any potential bacteria, organisms in the mouth. Now, there's no published evidence, and I want to make sure, and the ADA site, the CDC, ADHA really did a nice job of putting out the document. Go to adha.org. I mean, it's your site as a dental hygienist, and look at the report. Joanne Grenlian, there was a task force of recommendations for, just, I think ADA has them. We have them specific to hygienists. Joanne Grenlian and Kathy Eklund, some of the smartest women probably in the world, the recommendations. And the one thing that, is I read almost in every document is there's no published evidence regarding the clinical effectiveness of the pre-procedural rinses. So that's kind of leading up to our procedures. I mean, we've got all these things. We've got this new normal. You've got all the things that you have to do. And now, before you even get to your patient for the scaling and replaning, or, whether they're a 6-month recare or your 3-month perio patient. So, we really want to look at instruments. What are you using? How are you choosing your instruments? Do you have too many? We need to simplify our kits, and we're going to move through some of that. Now, one thing I do want to mention, I should have said it up front, we're going to allow time at the end of the lecture for questions. So we're moving right along, and we will answer questions at the end. So, you know, we know that things have changed, and the CDC and other organizations are telling us to avoid use of aerosol producing devices if at all possible. Okay, and we have that that dilemma. Well, standard of care is that blended approach with hand instruments and ultrasonics. What do? We're smart men and women. We will do the right thing. So, but I'm putting an X in there because we're not going to really talk about ultrasonics. But what we do want to talk about is, you know, our treatment instruments. And we need to determine what is the disease state, because the disease state should dictate what instruments that you use. Some of us we have one or two instruments for our easy routine recare patients. You know, there may be 6 or 8 in the cassette, but we use a couple. So, you know, we want to look, these are the things we're going to look at. We're not going to look at implant curettes. This is a 1 hour, we even say 50 minutes because we want to allow for time for some questions. But we're not going to talk about implant curettes tonight, although I certainly know that standard of care. We're going to look at some popular sickle scalers. We're going to look at our common curettes, but some curettes that are underutilized. We're going to go back in the day to the periodontal files and diamond files and how helpful those are, especially with those patients with difficult tenacious calculus. So we're going to look at our periodontal instrument based on our patient, the patient type. I think that's extremely important. You know, what is the disease state? What's the pocket depth? That's why we probe, so we know, and then choose the right instrumentation. This is pretty standard, and I will disclose this. When I do this live, you know, everyone has the instruments in front of them. We have our typodonts, and I also use an Elmo that, you know, where I can show the instruments and talk about some of the features. And, you know, it's my bad that I did not connect in advance because I just assumed that Elmo would just work and I could switch screens. So we're not going to have Elmo, and Elmo's just like my right hand. I guess guy, it could be a girl, but Elmo's a guy's name, in my opinion. So I would be showing these instruments, but we're not going to be doing that. So for some of you who are going to, in the evaluation, say, oh gosh, it would have been really great to see the instruments, you know, it just doesn't work well with a 1 hour webinar. Another day, we'll do something live. But these are very common historical treatment instruments, and they're in the dental hygiene school kits, and they really haven't changed with the exception of the Savannahs, the Nevis, and the Montana Jack. But traditional diagnostic was either the Williams or the Marquis. And we all know now one of the leading diagnostic instruments as far as a probe is the UNC 12, because it's just more accurate. And then we can even take a step further and have the UNC 15. But this is historical treatment instruments. Explorers, you know, we are so fortunate, and we have the Old Dominion University 1112, which has a similar design to the Gracie 1112. The Explorer 5, I always say the ODU 1112 is the dental hygienist Explorer, and the Explorer 5, which has the shepherd's hook and the number 17, is the favorite of the dentist. And if you have both of those on in your cassette, everybody's happy. I can imagine treatment without that ODU 1112. It's just, just envision the Gracie 1112 and it, just really, well, the Gracie 1112 is on steroids compared to the ODU 1112. So excellent explorer for a dental hygienist. It's so thin, you can detect the calculus, any kind of irregularity, deep subgingivally. You're not going to get very far with an Explorer 5 or Shepherd's. Sickles, we all know, 204S, SH67. I still today, I think that for most companies, those are the two top selling instruments over all instruments. I believe probably even the Montana Jack's pretty darn popular, but I think that still the 204S and the SH67 are the top sellers. They are for Asler, and I feel like that's the case with most of the dental companies out there who sell instruments. And then came along, this is newer, this is, I'm saying historical treatment instruments, the Savannah, the Nebby, and Montana Jack. But in another slide, we'll talk about these instruments because they're excellent instruments. The Gracie curettes, that's been the tradition. Even today, when I talk to hygienists, they are using the standard, the 1-2, the 7-8, the Gracie 11-12, and the Gracie 13-14. We had, and I always think, gosh, it just seems like yesterday, but it's probably 25 years ago that the Gracie 15-16 and 17-18 were introduced, and those replace your 11-12 and 13-14 for your mesial and distal. But again, traditionally, it's that standard set of Gracies. The universal curettes, and I know many of you just say, I don't want the Gracies, give me universals. The standards are still the Columbia 13-14 and the Barnhart 5-6, top selling, and I would think for most companies. So as we look at the instruments we're going to choose, and when I think about that Columbia 13-14, I honestly, that I can remember now, I'm 63, and I'll just turn 63, in fact, and my memory is pretty good, but I don't remember everything. I don't ever remember using that instrument because it's short and it's fat, and I always liked instruments that were fairly thin. That's why, like many of you, the more worn that instrument is, the better it is. It fits, but of course they break and you can't get them sharp anymore. But when I think about the roots, and you've got to know your roots as you select instruments. You know your patient, know what their disease state is, but it's so important that we remember the root. That every tooth has its own personality, and the challenges for certain instruments. So you know your roots, you've got to think, you've got to visualize what that root looks like subgingivally. And most of us can easily do that because we had to carve the teeth out of wax or soap. And many of you newer hygienists didn't have to do it. I just don't think that's fair. I think everyone should experience, have the experience I did. I think my teeth were thrown in the trash can like 3 times. And I remember the doctor, I won't say his name, although he's passed on, he told me multiple times that maybe I should consider a different career. I think I did okay, but I struggled with carving those teeth. So, just remember, ask yourself the questions, minister about the morphology, does that maxillary lateral incisor, does it have that palatal gingival groove? Sometimes it does, sometimes it doesn't. The canines, they can have a very prominent proximal root concavity. I have that very deep concavity, and it up until my new hygienist, I had burnished calculus, and it took both of us to get it, but eventually we did. I would just, for no reason, I could feel the puffiness. It would bleed when I flossed, and I knew I think I do a pretty good job. And so you've got to know these roots, and molars. You've got to know the location of the root concavities as well as furcations to choose your instruments, because not all, as we try to have one size fits all, it doesn't. And you don't need 15 instruments, but we need to really know what the root structure is, the morphology, and then choose our instruments. This would be, this is pretty traditional. We've got our inserts, although I do not recommend, I don't recommend putting your inserts in your kits, because I personally don't think we should be putting them in the ultrasonic. That's a whole nother course. But this is this is a Gracie. I've got red code rings on Gracie and blue on universals. How many of you really use that many instruments? I mean, they look good and it feels good to have that many, but we don't use them. When I do the live courses, we do the throw up the hand, raise your hand, and sometimes I even say close your eyes and answer the question, because sometimes we won't answer correctly because we don't want other people to judge us. So it's just we don't use that many. But we don't want to let go of anything, because we think, okay, if I don't use that instrument, budget for that, I can't use it somewhere else. So anyway, as we choose our instruments, it's very important. Yes, I'm a patriot, made in the USA. The best steel is the good U.S. domestic steel. And there are many instruments. If you go to a live convention, I'm not sure when we will be doing that again, but if you go and you see these vendors set up and there's a table and the instruments are, $9.99 each, well, guess what? That's what you're getting. There's a reason that an instrument is $40 or $50, and it has to do with the quality of the metal. So, most instruments that are manufactured in the USA with domestic steel, they're going to last. And ask even your dealer. I know they are representing, they're distributing for the manufacturers, but ask the question, hey, where are your instruments made? And there may be, they may not know, but they can find the answer for you. Kind of some of the current trends as far as instruments that are used by hygienists, and I'm sure in the world, but U.S. is my focus tonight. We hear a lot of the Everedge, and the claim. I mean, there's bigger claims and a lot more information, but we're not going to go into that in a 50-minute lecture, because we want to allow for questions. But the hot items out there are the Everedge. The claim is not that you don't have to sharpen. The claim is that it stays sharper longer than other instruments. So if you're using Everedge and it dulls, and you're upset because they're dull, sharpen them. The company that does make the claim that the instruments do not have to be sharpened, that's the XP, that's the American Eagle. Of course, Everedge is Hufredi. So but the only I would say Everedge holds its edge. That's their claim, longer. XP, you never have to sharpen. And LM, which is in the upper left-hand corner, the colorful cushion instruments, or I don't really think that's cushion grip. But those are the LM, and they're the diamond instruments, and those do not have to be sharpened. You move over to the far right, and most of you probably are totally unfamiliar with Kohler is an amazing company. They provide a lot of the surgical instruments that come into the U.S. It's a German company. They also, it's called Gracie Durability, very similar to the metal that's used with EverEdge. So that's something newer. Montana, the PDT, you see the that cassette, and Brasler instruments. You know, those are your traditional, and then I can have Premier there with my, if I had my Elmo, I would have had shown you all these instruments. But these are your traditional, it's a 440A surgical stainless steel, but the cryogenics in manufacturing these instruments exceed what would be standard. So they too are going to hold their edge, and at probably a more reasonable price for some of our budgets right now. How do you simplify your cassettes? Because we have a massive number of instruments, 10, 12. I mean, we go from that to 2. So, but I think most of us, it's more on the higher side. You want to first identify the instruments necessary for your examination. And in a recare, routine maintenance, you may have combined 2 instruments and have an X-Pro that has the Shepherd's hook on one end and the UNC 12 on the other. But I mean, personally, I would recommend having the ODU 1112 Explorer in there. If you look down in the bottom left-hand corner, you will see that instrument, the ODU 11, is in that pack. Then you identify the instruments that you're going to use on every patient. And it may be 2, maybe 3. And then your containment. Are you going to put them in a pouch or in cassettes? And I think the trend is definitely cassettes. Not only is it safer, it protects your instruments, and it saves you time because you're just putting them back in the cassette. You're not handling them or someone else multiple times. So simplify your recare maintenance cassette into, I mean, you probably, can be 2 to 4 instruments, and 2 of those are diagnostic. This is probably my favorite slide because it does show you a great comparison of the 3 most popular universal curettes. And for those of you who prefer universal curettes over Gracie's, the Columbia 1314, I said, I know many of you are fans. I just, it's really too short for effective instrumentation if you've got a periodontal pocket. I mean, I think that's a given. We all know that. And if you look at how long the terminal shank is, it's 5 millimeters. You can't, and it's fat. I've had hygienists say, but I love it in the furcations. It doesn't fit in the furcations. If a standard Gracie doesn't fit in a furcation, this is fat, or it's certainly not going to fit. You might dig around the furcation area, but it does not fit in that furca. The Barnhart 5.6 is very similar to the Columbia 1314, but it has a longer, thinner blade, which improves the access in the tight gingival areas. And that terminal shank is 7 millimeters. So it's thinner than the Columbia 1314, and it's longer. So that's a good comparison when you're trying to reduce the number of instruments. A Barnhart 5.6 for routine maintenance recare is just a really good choice. And then if you want to have an instrument in that universal cassette, and many hygienists actually have the Barnhart 1.2 in a Gracie SRP cassette. The Barnhart 1.2 has a 10 millimeter terminal shank, and it's a much longer, and it's one of the thinnest instruments among the universal curettes. So, those are really good choices. And when we are spending more time with hand instruments versus universal, you also need to go back to, okay, what is the state of the disease? I've got some pretty tough calculus here. is this instrument, the Barnhart 1-2, is that instrument, is it rigid enough for that more aggressive scaling? That's probably not a good word, but you really have to work harder when you're scaling tenacious calculus versus having your ultrasonic. So it might be a little boingy. That's an Anna Pattison word, by the way. I just love it. Flexible just doesn't ring very well. But I've had hygienists tell me that they've broken Barnhart 1-2s, and I don't have a photograph. But if you're breaking Barnhart 1-2s, then maybe you should go to try the Columbia 4R4L. That's a very popular instrument used in perio practices. And I would recommend that if you find that you're breaking an instrument. But always read the indication. Every company, they should have an explanation of what is the purpose of that instrument. That's very important. So the example, these are popular posterior scalars. The Savannahs, Brazel-Hezolani Savannahs, Hufredi has the Nevis, and then PDT has the Montana Jack. All of these are very popular for medium to have, or this is light to medium, but I would say more medium calculus. Your Nevi 3 and your Savannah 3 are probably, I would say, light to medium, but I think that I need to change that, and it should be medium to heavy calculus. And excellent instruments. Montana Jack is well known. Hygienists love it, but I would recommend having one of these instruments in every one of the sets. And there's also other companies that have like instruments. I think Blackjack. I mean, there's different names. On the universal side, Langers are very they've been around. They're old instruments, but they're coming for the people who like universals. These are designed like Gracie's, but they're universal. You've got a Langer 1-2, which is like a universal Langer 11-12, and then a Langer 13-14 would be, or Langer 3-4 would be like a Langer Gracie 13-14, excuse me. And then your anterior would be like a Gracie 5-6. And the only difference is, they're just universal. And for hygienists who would like to like the idea of a Gracie but want universal, this is the answer. Go with your Langers. And they are more rigid than your standard finishing Gracie. When you're, and moving right to the Gracies, and we're going to move kind of quickly here. Again, the same thing. Identify, this is a traditional Gracie setup. Identify your diagnostic instruments, and then you want to identify your treatment instruments. And this is, I put this, then, your Gracies, you're going to have your standard set, 1, 2, 7, 8, 11, 12, 13, 14, or you may have the 15, 16, 17, 18. There's no substitution for those. But instead of the 204S and the 8687, you might, it's hard to not have the 8687 as your anterior sickle. So you've got that, and add in a Montana Jack, a Nevi, or one of those type medium to heavy posterior sickle scalars. So just reduce. Do you really need all these instruments? And a lot of hygienists are taking out the Gracie 7-8. The terminal extended reach for those deeper pockets. Remember, a standard Gracie only reaches to 5 millimeters. Beyond that, it does not work. You want to look at your extended reach instruments, which are, this would be your after 5s and mini after 5s, your insight pocket scalars, your mini insight pocket scalars, deep pocket, access. Every company has them. But the big difference is there's 3 millimeters of longer in the terminal shank in both the after 5 and the mini after 5. And the blade of the mini after 5 is 50% shorter. So those instruments can really get in some of those concave areas on the molars or any of the teeth for that matter. A new, I say new, but it's probably been out 15 years. The micro minis are maybe, close to it, maybe a little longer. The micro mini Gracies are just, they're 20% thinner than a mini after 5, and they're elongated, but these are finishing instruments. These are not suitable for heavy calculus. These are going to be finishing, but they will fit in the furcations. So that length you'll be able to reach, but you can reach a furcation, but you're not going to be aggressive with these. These you will break these. So this is just comparing a mini after 5 to a micro mini, but I think everyone should have these. But those are set, like sometimes like our SRPs, those are set aside and we go get them when we need them. This would not be in every cassette. Your rigids, those of you who are hand scaling only, you need to move away from standard Gracies and only use your rigids, because these are they're designed for more tenacious heavy calculus, because that the shank is much thicker and stronger than the standard Gracie. Again, it's not boingy, and you're going to be a lot less tired. You're not going to have that hand fatigue at the end of the day versus using standard. All of the same designs, but they're just rigid, so they're going to be more, they're going to be thicker and less boingy. And we're the final 2 slides as far as some of the newer instruments. Files are very old. Files, it's not a new instrument, but they're used to, you've got the rigids, and they're used to crush or prepare that calculus deposit. You can go in there and just roughen it up, especially burnished calculus, and then go in there with a very sharp Gracie or universal. You're going to lay it flat, the teeth flat on the deposit, and use, just some oblique or, horizontal strokes, but staying on the calculus, not the tooth, because you don't want to damage the tooth. So, place it on that burnished calculus. You can also use files. You don't need a lot of these, but every office needs, a couple of files. And there's, the Orban and the Hirschfeld. The Hirschfelds are thinner, which I kind of prefer those, but to have an Orban for the thicker, heavier calculus. Diamond finishing files have been around. They were introduced back in the early 90s, and the original designs were single-ended. They were really skinny, and they were from Germany, and Brasler did introduce those. They were the first company to, it was a first for the company, and they were around for many years. And then we went to a double-ended, more ergonomic instrument. And these are like the micro minis. They actually fit in the furcus, and because the diameter is so small, these are 360 coated with the diamond. And it's a very ultra fine diamond, but it's you just use a very light stroke, and there's a mesial distal, and there's actually 2 mesial distals. This instrument has a little bend on the end, the M, and that just the little bend just seems to fit better in some of the areas. But every hygienist has their choice. I think if you choose one, this buccal-lingual reciprocal 1-2, it fits anywhere. It's kind of like you think it fits where it fits. So key things, replace your instruments. The life of an instrument is 9 to 12 months. And with some of the newer instruments, are lasting much longer. If you sharpen frequently, you will preserve your working end. When the instrument becomes too thin, you throw it away. It's got to be discarded. The same thing with your inserts. You can't remove this calculus if you are using dull instruments. You also are going to cause over-instrumentation. You're going to have this hourglass look. Inserts, make sure you're measuring them. They don't work. You end up applying too much pressure. You're not using enough strokes. You've got to discard and replace your damaged inserts just as frequently as you do your hand instruments. They don't last 5 and 10 years. And I know some of you have some older inserts, so we want to make sure that you are replacing those, even though we're not using inserts as much right now. But many of us are. Just a review, and then we'll try to answer a few questions. Sorry, there's just a lot of information for a quick hour time frame. You establish and follow your office protocols that align with the CDC's guidelines. And your office protocol will determine, are you going to use ultrasonics? Do you have the PPE? And I think most of us do. And as I've said many times, we're really smart men and women. We're going to deliver the best standard of care and deliver it safely. Simplify your cassettes. We don't need all those instruments. Take out some instruments so you can add in some of the diamond files, and you only need a few. You don't need a lot. These are instruments that are for furcations. Your files are for burnish calculus. Know your instruments and know your roots. Choose high quality instruments. You're going to pay more for high quality instruments, and sharpen instruments at the first sign of dullness. If they don't sharpen, discard them, because they're too thin and you will break them. And if they may be thick and you've just never sharpened them, so they're not going to sharpen if you've exceeded the life of that. So we are getting close. So what I want to do is we're going to do a little Q&A. I'm going to ask, let's see, we've got a few minutes. I think they'll let us go over just a little bit with the questions. What does the cordless polisher have to do versus a corded one? Well, they do the same thing. It's just ergonomically, the cordless is very popular because you're not connected. Ergonomically, it's just an ergonomic preference. I think that if that's what you're asking. The corded, they do the same thing. A corded one has a little more power for removing stain, So right now we're just wanting to polish our patients and not have a lot of splatter. The corded would have more splatter. Let's see, have studies been done on Cavitron aerosol minimization using suction, leave rubber dam, or isolate? Isolate. I don't have an answer to that. I should have read that, but I think we're so new into this aerosol reduction. We've always had aerosols. I'm surprised that we didn't deal with the aerosol issue before we had the pandemic. There's a lot of information out there, but I don't know if a specific study has been that is comparing these different items. I don't think so. What is my preferred sharpening tool? I love the Gleason guide and the sharpening horse. You can Google those. If you want a tool, I think those are the easiest. Premier also has the Edge. I think it's the Edge. I can't believe I just lost it. They have a really nice aid too. Not a machine, but it's an aid. I'm just reading through here. A lot of repetition. Oh, someone asked, what would I recommend instead of the air water syringe? I don't think we have, I hear hygienists are letting their patients get up and rinse when they polish. Otherwise, you're using, I would just follow, if you're polishing, closely with your HVE so that you're getting the splatter and the patient's not tasting all that. All right. Yeah. All right. Diamond files may not need to be sharpened, but they do wear out. Loser diamonds. Absolutely. Thank you. They absolutely wear out. They never need to be sharpened. But now I've had hygienists who tell me they've had theirs 10 years. I think the original one, diamond files were much better than the newer generation of diamond files. The German diamond files, I think, were superior, but they do wear out. Throwaway instruments, why not retip? Oh my goodness, I could spend 20 minutes on that. Retipping is I'll say it this way, hygienists are not using their cavitrons. They need a superior instrument, not an inferior instrument. Retipping is a softer metal. The tips are not very well balanced. That's a whole nother lecture. We should do a lecture. How long do diamond instruments last? It depends on how often you use them. It's not an instrument you use constantly like you do a Gracie 1-2. So you may use a diamond instrument, once a week, twice a week. The more perio patients you have in your practice, you would use that more. Why did you say that Gracie 7-8 is not used as much? I have a lot of hygienists when they like at meetings and they're preparing their kits, they're replacing their Gracies. They're going with a 1-2, 11, 12, 13, 14. They say, okay, I can do the same thing with my 1-2 that I do with my 7-8. So if they're going to reduce an instrument, I'm not saying that's always the case, but if they're going to reduce an instrument, it would, oftentimes it's a 7-8 because they feel like they can do the same thing with, yes, obviously the blade is not as long, but you really need to be using more overlapping strokes anyway, or you're going to miss some of the areas, especially where you've got a concavity on like the canine I was talking about. What do you do to replace polishing at this time? I think more hygienists are polishing than not, but there are a lot of hygienists who are just having their patients brush. Anything to avoid the aerosol. For hand scaling, are you suggesting use of a level mask? I think the recommendation for PPE is, I think with the current pandemic, is a minimum of a level 3 mask if no aerosols. Because with a level 1, with with just breathing, you're saturating. I think it's I think I read something from CrossTech years ago that you would have to replace every 20 minutes. So I think in the current environment, a level 3 is the minimum, and you don't put yourself in that situation, expose yourself. And I think they're going to let us have I got 2 more minutes because I can go to 8:05 with a question. Is it a good idea to send out sharpening? Sure, if you've got the budget. How often? If I was in practice, it would be too much because I want razor sharp instruments. The best answer is to learn how to sharpen and always have a sterile stone. So if you need to do a couple of strokes, you can do that. Yes, that someone just reminded me. The premier sharpener is the disc chairside sharpener. It's excellent. I have two of them that I use when I teach my sharpening courses. Um, yeah, brushing does create some aerosols as well. There's I think we're going to have to close down now. I don't think there's a clear answer. We're learning daily. I'm certainly not an expert in the right procedures for this pandemic. I'm just, wanted to cover some of the things that I'm learning with you since I had the audience tonight. We're going to close. Thank you all for your time. I know it's been a long day, and hopefully we can do this again sometime. Thank you so much.